There is clear evidence, lots of literature, studies, much smarter people than myself who've written about how depression and anxiety affects your outcome from surgery. Our problem has been we've ignored it.
There's a whole lot of conversation and a whole lot of evidence, honestly, around integrating behavioral health into primary care settings, the behavioral health integration and coordinated care. Um, but I was speaking with Dr. Covall here with regards to, well, and he actually talked to me about some deeper ideas around, well, what about the behavioral health integration into specialty medicine as well? So just quick intro, Dr. Covall has done so many amazing things. Could you tell everybody what you're up to?
The interesting thing about this is that I'm trying to develop a health platform, a digital health platform, using the new technology, the new enablements to follow the journey of an individual longitudinally. So, meaning as a person ages, as they go along, using what's available to make their outcomes, their life, their quality of life better. And for my interest specifically is more along the lines of surgery and such. So surgical outcomes, medical outcomes, that type of thing. I mean, healthcare right now is in serious trouble, and I think we can do a whole lot better for patients.
I mean, just having started my career in healthcare technology back in 2008, it has come a long way to where now we're looking at entire patient journeys rather than sequestered areas of care. And at the same time, I think that a lot of people in our audience, especially like being focused on the behavioral health side, are really drained by the fact that behavioral health has been its own silo, when there's truly so many more connections into physical health that should be addressed upstream.
I think healthcare, generally speaking, has been locked in silos for so long. So it's not just behavioral health. You can't separate physical health and behavioral health or mental health. I mean, like for me, I'm interested in musculoskeletal wellness. Okay. I'm an orthopedic surgeon. I was until last July. There is clear evidence, lots of literature, studies, much smarter people than myself who've written about how depression and anxiety affects your outcome from surgery. And our problem has been we've ignored it. And I don't think that's right. So there's clear evidence that if we address those issues prior to the surgery and during the recovery, patients do better. They're happier. They're more satisfied. We meet their expectations better. All really good stuff.
So this leads to a really big but really simple question, honestly, is given the evidence and given the the conversation about it, why is it ignored?
And it still has to do what you just said. Everything's in silos. I mean, so healthcare has become more and more subspecialized. Okay. Once upon a time, orthopedic surgeons did all of orthopedic surgery. They did fractures, they did, sports medicine, they did total joints, they did spines, they did all the things that you do in orthopedics, what we train in our residency for. Now everybody does something very specific. Everybody is subspecialized. But the problem is information doesn't flow in all directions. And that's the problem.
It obviously becomes extremely difficult to understand how to properly address something so far outside the domain.
Yeah, you have to have an interest. I do have an interest in mental health, behavioral health. I do believe it impacts what I do in total, which isn't everybody's thing. The healthcare has become more and more like these lanes, and everybody stays in their lanes. Because, like, if I prescribe an antidepressant for someone, some government agency is going to say, or some payer is going to say, why are you prescribing Lexapro, an antidepressant, for your patient, you're an orthopedic surgeon. Then I have to explain to them that, well, Lexapro is good for anxiety and depression. That actually gives them a better result from their knee replacement. And then there's also the fear of legal liability.
So we have this culture, and sounds like increasingly so, of having to stay in one's own lane for a myriad of reasons, training, fears, liabilities, and things like that. Is there some sort of quantifiable economic cost that's been associated with this, like the cost of behavioral health and mental health challenges going unaddressed during the relationship between?
You know, it's a great question because to quantify that is difficult. In surgery, it's a little bit easier because there's a bigger cost. It's, you know, you have a cost of an implant, cost of OR time, wherever. Behavioral health is difficult, and it's also kind of difficult to measure how well someone's done. And so how do you prove that wherever money you put into it has done well? I think we will need to, in our current status of value-based healthcare and bundle care and the way that payers look at things and the government payers, the federal payers, Medicare, Medicaid, and such, they're looking at ways to prove that what we do actually helps, that it's worth the money that they're investing into it. So we're going to actually have to find a way of doing it.
Yeah, and the shift towards behavioral, towards value-based care and these managed scenarios, I think, is opening up the door to more conversations like this, and eventually, because it's conceivable how you could come up with the cost through like a randomized control trial setting that looks at people that were undergoing various behavioral health interventions or even digital health interventions at the same time they're managing like their experience with their knee surgery.
That, honestly, that would be the best way to prove it, because you actually, I have a way of doing that. Because you can actually prove something objectively, that if you modify and optimize their behavioral health prior to surgery, and they do better in a shorter period of time using less resources, well, then you've saved money and they've done better, which is both. I mean, ideally, that's what you want to do. You want to get better outcomes for less money.
I focused in on the cost element, and the reason I did that is because we just have so many conversations on having to make the business case for everything, which is extremely important. You were really focused on the personal element and what people are going through the moments before they go through undergo a surgery.
Yeah.
Could you talk about we have a framing of how we might get to the economic cost, but could you also talk about the personal cost if we're not addressing behavioral health issues?
That's how I got started realizing that, you know, there's more to everything that we do, that you have to look at their emotional stuff. Now, so getting to your question more specifically about prior to surgery, how do you get the patient ready for surgery? Okay, so that means optimizing their medical conditions, their blood sugar is under control, their blood pressure under control, you know, so forth and so on, including, I think, their mental health. You know, there are people who just think the worst is going to happen. If they don't expect a good outcome, they probably won't get a good outcome. And so you have to deal with that beforehand. So there is the optimization of their health in general, physical and mental, to get them ready for surgery. And then there's the recovery process. And it's hard. It's hard work. It's painful. You can't always do what you want to do when you want to do it. and you need to be educated to figure out how to manage things. So there is that behavioral care, mental health aspect that may be probably more important to follow and evaluate and impact after surgery. This is an article written by friends of mine, Victoria Brander and David Stolberg out of Chicago.
What's the name of the article?
Predicting Total Knee Replacement Pain. In here, the thing that I want to read is preoperative depression and anxiety were associated with heightened pain at 1 year post-op. Pain after knee replacement resolves quickly, declining in approximately 1/2 by 3 months, which is true. However, 1 in 8 patients report moderate to severe pain 1 year after surgery, despite an absence of clinical or radiographic abnormalities. But they have those issues ahead of time, and they have depression and anxiety, which is why, 1 in 8 people don't do well. Now, the interesting thing about total knees is no matter what we've done, 10 to 20% don't do well. And I believe no matter what, is because we've never really dealt with their mental health well. Considering that there are 2 or 3 million total knees done a year, that's a lot of people.
Honestly, I was a little bit pointed when I asked that question around the personal cost, because this is just something that I've experienced in the past week. I didn't recently have surgery, but my mother did. I feel that having her there and other people myself there and others there to support her, especially while she was in the hospital speaking to her doctors and nurses, I think that there was a power in having the family there.
Family support is huge. Family support is really, really important. Family comes in different forms, as we know. But support of some kind. And unfortunately, there are some people out there that don't have that. So, what we need to provide them is with support in other ways. One of the problems that we don't quite do that yet. A lot of my friends' parents are at that age that they're passing away. They're getting sick and dying and such. But I would help them deal with it and from a medical perspective, but also a supportive, most people don't understand half the things they're told by the doctors and nurses. I don't even understand half the things I'm told when I'm in that situation. And that's why I think education prior to surgery is really, really helpful. So, because if you can get them prepared mentally and just in the family, you need a caregiver that's really involved and listening, because, a patient kind of goes in one ear and out the other. You need someone else who kind of listens and kind of reminds them of what's going to happen. I think that we're on the verge of really cool stuff that can help people, and I think getting back to what we started talking about was how you integrate all these things. I want you to talk about how you see integration. How do you see that?
A major part of the integration story is for things to exist within their workflows, so that they're not having to learn additional systems to go out and access that information. But on top of that, like but even broader than that, though, people don't want more data thrown at them in their own workflows without having a context or an understanding. So that was one of the things I was wondering about, is on how you're taking important and meaningful data elements and turning them into information that people can consume and act on. That's one aspect. And the other aspect is where a conversation like this gets people to focus on why that data matters, why that intervention matters, why somebody's behavioral health state has some context into the care that they're managing.
I totally agree, and actually, it's why I want to do what I want to do right now. My idea for a platform, digital health platform. The platform is for 2 reasons. One is to actually try to help people now. as they go along, to educate them as they go, but is really, really, really important and very valuable to collect all the data all along. That's where we can start understanding how to treat people. My goal is a simple one. Complicated as hell, but a simple one. Let's say we have 4 groups of people. We have young, old, female, male, and then you break them down into much more categories than that. Then you decide what treatments are available for that particular disorder, for that particular cohort. You have cohort A gets treatment B, and most likely will get outcome C, which is what you want. So to improve your outcomes, surgical, medical, behavioral, wherever it is, you have to start understanding what your treatments are, what treatment options are, what person gets what treatment so they can get the best outcome for that particular person. That's something we don't really do now, not necessarily. In orthopedic surgery, total joints, they use robots and this and that, but basically their goal is to do kind of the same thing for everybody and to get a kind of textbook outcome, which is great. But that doesn't mean it's going to be great for that individual patient.
These are important conversations that we're having on, and I'm seeing it more in terms of you have maybe an overall performance score, something that looks good overall, but then you start breaking it down by in bases under ethnicity, gender, and honestly, it's especially true on the gender spectrum as well.
Yeah, absolutely.
There's a whole lot of conversation, a whole lot of work being done on. Okay, well, now that we understand, and I'm talking more on the population health perspective.
No, I can go down that way too.
Yeah, but you're bringing on an extremely important point that a lot of the testing that has been done on various interventions has been on like single populations that might not be representative of.
Oh, you don't know how badly we do research. It's actually really, really sad. A lot of medicines are tried on white males. How do they do with Hispanic females? I mean, it doesn't make any sense to me how we got down this pathway, but we did. Now, part of it has to do with who volunteers and such, but health equities sucks. And we don't do enough to understand the different groups of people and what they actually need to get better. And then you bring in, okay, now we're going to bring in behavioral care, all that fear. Different ethnicities have different fears of physicians, extremely different. You probably know Georgia has probably the worst maternal health statistics. It isn't the worst. We're like 49th out of the 50 states. So we're next to worst of maternal health in the United States. Like, the weird thing about it is some of it has to do with Black women who have fears of the doctors that have been around for a really long time for really good reasons.
Yes.
That aren't ever addressed. And that's not good. I mean, both aren't good. Is that we're not actually treating them or preparing them or, getting to understand that that fear is, I don't want to say unreasonable because it is reasonable. But somehow we have to get past that to get better outcomes.
It's easy to undermine trust, and it's hard to get it back.
It's
Literally impossible, because like once someone does show that bias, which I had a conversation about bias recently. Like I was taking a very aggressive stance towards it, but it does turn out that there are people that are receptive to correcting those problems with themselves.
I'm not saying I know how to fix it. I don't. I mean, we all were raised certain ways, and it's hard to eliminate certain biases. We need to do better of understanding and adjusting and getting back to your research trials and such, which is really sad.
I want to go. There's just so many areas that we can go deeper into, and there's just this question that we always ask of every guest, and I want to have more conversations and everything like that. But I want to round it out with if you're given a magic wand, where there's one thing we have to, like the challenge is you have to focus on one thing to change with our healthcare system. What would that be?
One of the things I would love to see, and we're heading in that direction, is more interoperability of databases of such, so that we can learn and not have to repeat everything. If you go to the hospital emergency room and you broke your arm, let's say, they take an x-ray and they said, you broke your arm, I'm gonna put you in a splint, you need to see the orthopedic surgeon tomorrow. Okay. You show up tomorrow in the orthopedic surgeon's office and you're in a splint, and that's all the doctor knows. You're in a splint. The hospital can't send the x-ray over. You don't really want to go back to the hospital because you're in pain to get the x-ray. And so the doctor said, well, I can't treat you unless I get another x-ray. So you get another x-ray. So now you have 2 x-rays in 2 days, just so you can be treated properly, which they couldn't do the first time. But think of that tenfold. All that extra money. There is a study that was done back in 2002 that looked at this specific thing, and 1 out of 3 healthcare dollars is spent on repeating tests.
1 out of 3.
Yes.
Wow.
So we could save 1/3 of our healthcare costs just by making sure that everybody had their information and not needing to repeat it.
I'm going to say that that's an extremely powerful magic wand, because what that magic wand does, there's an implication between 2 organizations that are sharing data between each other, is that they are working together on a goal, versus the competitive mishmash of organizations hoarding the data they have on their certain patients. So your magic wand ripples into the way we deliver care.
Isn't that amazing?
I like your magic wand a lot, and I think that it resonates with people that are, there's so many organizations, so many leaders that want to reduce all this friction and unnecessary testing and everything like that, because we're looking at the patient as a whole person. So the big question then is, if people want to connect with you and talk to you about that, what's the best way that people can get in touch?
It's rdim.inc@gmail.com.
Okay, fantastic. So again, I'm extremely thankful that you came here and shared deeply. I like the attention that behavioral health integration is getting in the primary care setting, and I just thought that this would help open the conversation for people who are already interested in that, and just start some thinking down those specialty care lines. So thank you very much, folks.